So good evening, everyone. So today I'm going to discuss about chemoradiation in carcinoma rectum, a systematic evaluation. Why I have chosen this topic? Because I always find very difficult to understand the multimodality approach in carcinoma rectum. We know that surgery is the primary treatment for carcinoma of rectum, but to get the better outcome, we need to do a multimodality approach, which includes radiation, chemotherapy, or chemoradiotherapy. Now, the sequence of these multimodality approach are, varies right from neoadjuvant radiotherapy alone, neoadjuvant radiochemotherapy, then post-operative radiation therapy or post-operative radiochemotherapy, or short course radiotherapy. So all kind of sequences of multimodality approach have been used in rectal cancer. And there are a lot of articles which supports the various sequence of these multimodality approach. So it makes me confused that what should be the ideal approach for a case of carcinoma rectum which require multimodality treatment. So let me just start my presentation. Now, first issue about the rectal cancer is that should we put together colorectal cancer as a single topic, because many books usually cover colon and rectal cancer together under a similar topic like colorectal cancer. So is it right that we should always discuss colon and rectal cancer together? Answer is certainly not, because rectal cancers are different and colon cancers are different. They have different pattern of care, they have different pattern of failure, they have different biology. If you look at the colon cancer, the recurrences are more common at distant sites, while the local recurrences are very less than 10%, but main recurrences occur at distant sites in colon cancer. And why we have such a low local recurrences? For the simple reason that the colon is a very big organ and surgeons may achieve a wide tumor-free margin irrespective of location of the tumor in the colon. And that is the reason that we get very small or very little local recurrences. So we can say that distant recurrences are more than the local recurrences in colon cancer, and most of the time, the distant recurrences occur within 2 years after surgery, and it certainly impacts our overall survival. So the main treatment which will ultimately affect the overall survival is systemic treatment. And most of the researches are being conducted in this direction, that how we can find out an effective systemic treatment so that it can take care of occult distant metastasis, thus improves the overall treatment time. So in colon cancer, most of the researches are being conducted to improve the adjuvant systemic treatment. If you look at the rectal cancer, the local recurrences is a significant problem in rectal cancer, unlike colon cancer. And the reason is that rectum is situated in a relatively narrow pelvic cavity, which is overcrowded with various organs, and it is difficult for surgeon to navigate freely in this overcrowded pelvic cavity and to find out a surgical or the tumor-free margin around the tumor. So that is one of the reasons that local recurrences are very common. And when we say a tumor-free margin, it is mainly problem in getting a distal tumor-free margin when the tumor is situated in low rectal region, and also the circumferential margin. Again, it is very difficult to get tumor-free circumferential margin, and both of these issues ultimately reflected in increased local recurrences in pelvis. While adjuvant treatment in rectum have been tried, but it has not shown to improve the overall survival as in colon cancer. If you look at the local recurrences depends upon stage, and an overall recurrences rate is around 26% in the pelvis. As I said, it depends upon the stage of the disease, which ranges from 14% in stage 1 to 46% in stage 3. As I said, another important reason for local recurrences is circumferential resection margin, because it has been seen that there is a sudden drop in outcome if the circumferential resection margins are positive in terms of local recurrence as well as overall survival. So in rectal cancer, main area of research are how we can improve the local control. Second, how we can preserve the sphincter and thus provide the colostomy-free life, because this issue is very, very important and it is directly related with quality of life. Third is how we can reduce the distant metastasis. So most of the future research are directed to address these three issues. Now, because of different pattern of care and pattern of failure and different biology, we can certainly say that rectal cancer is not like a colon cancer. Both have different, biology, both have different pattern of failure, both have different pattern of care. So let us come to our main topic, that treatment of carcinoma rectum. So what are the main issues in the treatment of carcinoma rectum? Now, mainly there are two issues. One is outcome issue and the second is quality of life issues. So when I say outcome issues, main area of research is how we can improve the local control or how we can reduce the local recurrences. Because local control is a difficult task, because mainly it is difficult to get a distal tumor-free margin as well as circumferential tumor-free margin. And regarding the quality of life issue, how we can improve the quality of life issue by providing more sphincter preservation surgery, or how we can avoid the colostomy, especially when the tumor is located in lower middle rectum or lower rectum. Now, this is very important. If you just imagine the misery of a person who is cured of disease, but person is carrying every time, every day, everywhere, wherever the person goes, a bag full of shit along with the abdomen. It is very difficult for person to, feel relaxed or feel, comfortable in the society. So if we can, improve the sphincter preservation ratio or sphincter preservation rate in carcinoma rectum, that is again a very big, achievement as far as management of carcinoma rectum is concerned. Now let us look at the local control, how we can improve the local control. There are two ways. One is by improving the surgical technique. The second is by using multimodality approach, which means that apart from surgery, we have to incorporate radiation plus chemotherapy. So we will look one by one. Let us first look how we can improve the local control by improving our surgical technique. Now we know that total mesorectal excision is greatly, has impacted the outcome in carcinoma rectum. We know the mesorectum is basically a fatty tissue which surrounds the rectum, and it contains the lymphatic that drain the rectum. So if you look at the pattern of spread, the local spread of rectal tumor inside the rectal wall, it has been observed that the extension of microscopic disease distally in rectum is not beyond 2 centimeters. Most of the microscopic disease are confined to within 2 centimeters. Even for anaplastic tumor, beyond 2 centimeters, microscopic disease has been seen in only 5 to 6% of the cases. So if you resect a 2 centimeter margin distally beyond the gross tumor, then you are sure that you will remove most of the microscopic disease in most of the cases. But if you look the spread of the rectal cancer outside the rectal wall, especially in the mesorectum, it has been seen that microscopic disease is spread beyond 2 centimeter or up to 4 centimeter. So if your resection margin is 2 centimeter distally, considering the spread of the disease intramurally or inside the rectal wall, then you will be cutting through disease outside the rectum in mesorectum, and there are fair chances that you may leave behind microscopic disease in mesorectum, and this will lead to very high failure rate, which is to the tune of 30%. So the answer is that you have to take a bigger margin outside the rectum in the mesorectum so that you can encompass all the microscopic disease which might spread up to 4 centimeter. So this means that we need to take different margin inside the rectum and the outside the rectum. So we have to take bigger margin for mesorectum, while for rectum we can take 2 centimeter distally. So it gives rise to the concept of tumor specific mesorectal excision depending upon the location of tumor. So if the tumor is located in middle and upper rectum, then you have to take a 5 centimeter margin extramurally distal to the inferior aspect of the tumor. Or if the tumor is in the lower rectum, then whole mesorectum up to pelvic floor should be excised. Same thing, just to make it more clear, that if this is the tumor inside the rectum, then inside the rectum or in the rectal wall, if you take a 2 centimeter margin, it is sufficient. But for extra rectal, fatty tissue, or for mesorectum, you have to take a bigger margin up to 5 centimeter or up to the floor of the pelvis. And if you do this kind of procedure, then you will be very much confident that you have taken care of all the microscopic disease inside the rectum as well as outside the rectum. As I said, another problem is to get circumferential tumor-free resection margin. Now, surgeons, have a consensus that if you want to achieve a tumor-free negative margin, then it should be 2 millimeter or more than 2 millimeter, between the tumor and the mesorectal fascia. So any margin which is within 2 millimeter will be considered as close or positive margin. So we need to take a more than 2 millimeter margin circumferentially around the tumor. Now this is the gentleman who gave the concept of total mesorectal excision, and he presented first time in 1982 his series of TME in carcinoma rectum. And after that, total mesorectal excision became the standard of care, and it has drastically brought down the local recurrences. In one of the series, it has been shown that total mesorectal excision has reduced the local recurrences from 30% to 10%. Now, this is really very amazing that just simply by improving a surgical technique, you have reduced the local recurrences from 30% to 10%, almost in absolute advantage of 20%. So this is really something very, very amazing in oncology. Now, we have reduced the local recurrences from 30% to 10%. Then the question was that should we or can we further reduce the local recurrences below 10%? This I will discuss in a short while, but let me first discuss the other surgical issues. Now, if there are adjacent organ involvement, then what should we do? Now, the surgeon usually do en bloc resection of all the adjacent organs which are involved by tumor, and it is usually seen in 5 to 20% of primary rectal cancer. Similarly, if there is an inadvertent perforation, then it carries a very bad prognosis. And it has been seen that if the perforation is just opposite to the tumor or near the tumor, then it carries a very bad prognosis as compared to when perforation is remote from the tumor site. But perforation overall carries a bad prognosis, and it should be documented after surgery. Now, other surgical issue, if you know what is the role of prophylactic oophorectomy, usually the normal ovaries should not be removed. There is no role of prophylactic oophorectomy because ovarian metastasis have been seen around 6% of rectal cancer cases. So prophylactic oophorectomy should not be done. But if there is an abnormal looking ovary, then certainly bilateral oophorectomy then should be done, because it has been seen that if there is an abnormal looking ovary or if there is a metastasis in one ovary, then chances of occult metastasis in other ovary is very high. So we need to do a prophylactic bilateral, or sorry, the bilateral oophorectomy rather than unilateral oophorectomy. Now, regarding quality of life issue, as I said, that it is closely associated with colostomy, or whether we can provide a colostomy-free life or we can preserve the sphincter. We know that usually the sphincter is lying down here. So depending upon location, we can preserve the sphincter. For example, if the tumor is situated in upper third of rectum, then you have enough, normal rectum through which you can pass your resection line and you can do end-to-end anastomosis, resulting into colostomy-free life. Similarly, if the tumor is located in upper middle third, still it is far away from the sphincter, and we can very well resect it with tumor-free margin without encroaching to the sphincter. But if the tumor is located in lower middle or lower third of the rectum, then certainly it is very difficult to save sphincter, and many times the sphincter is sacrificed. Ultimately, it leads to colostomy. Though nowadays with low anterior resection with the help of clips, it is possible in most of the tumor which are situated at lower middle third of the rectum, or upper lower third of the rectum, we can save the sphincter, but many times the disease is advanced and it is not possible to save sphincter. Usually as I said, we should always try to preserve the sphincter, but there are some situations where we cannot spare the sphincter, or we cannot save the sphincter, and we have to do APR with colostomy. So what are those situations? When patient is having incontinence, or there is pre-existing bowel dysfunction, or the tumor is situated in distal rectum, when we cannot take a 2 centimeter margin without encroaching into the dentate line, or when the tumor is bulky, or when tumor is fixed. So these are the situations where APR is favored from the very beginning. Remember that surgeon is a critical factor in overall outcome of patients, or we can say that surgeon is a prognostic factor in surgical outcome. And it has been seen by various data and various articles that if surgeon is well trained, or if surgeon is working in a high volume disease center, then the outcome is better as compared to centers which do not operate rectal cancer on a regular basis. Now, this is one of the such data which suggests that as the number of operation goes down in any center, the colostomy rates keeps increasing, which is statistically significant. Similarly, 30 days mortality also keeps increasing, which is again statistically significant. And similarly, 2-year survival keeps decreasing, which is again statistical significance. So it is very well established that the center where the treatment or the surgery is being done and the surgeon who performed the surgery is a critical factor in outcome of rectal cancer patient. Another thing is how, as I said, that with surgical technique, we were able to reduce the local recurrences drastically. But then again, the question is that can we further reduce the local recurrences, and at the same time, can we increase the sphincter preservation? Answer is yes, we can do it by using multimodality approach, which means that along with surgery, we have to incorporate chemotherapy and radiotherapy. So there are two ways by which we can intervene with this multimodality approach. One is preoperative intervention, other is postoperative intervention. I will discuss one by one. And this is mainly required for tumor which are T3, T4 or node positive tumor. So first let us look at preoperative intervention. Now in preoperative intervention, initially it was started with short course radiotherapy, which was added to surgery. So naturally, a lot of trials were conducted to look at whether preoperative short course radiotherapy was beneficial versus surgery alone. Now, once its role was established, then the next question was whether long course radiotherapy was better than short course radiotherapy in combination with surgery. When after this, the third step was, because then, you know, we started using chemoradiotherapy for most of the tumor sites. So it was thought that whether addition of chemotherapy along with radiotherapy will be better than radiotherapy alone when we used it in preoperative setting. So these are the three headings under which a lot of trials were conducted. So I will discuss only important trial under each of these headings. So let us first start preoperative short course radiotherapy plus surgery versus surgery alone. Now these are the two landmark important trial. One is Swedish rectal cancer trial, the other is Dutch trial. Both trials are similarly designed. They are very much similar in their design. If you see the resectable rectal cancer two-arm study, in one arm, neoadjuvant short course radiotherapy 5 gray 5 times followed by surgery, other arm upfront surgery. Similarly here, one arm 5 gray 5 times short course radiotherapy followed by surgery, other arm direct surgery. The only difference between the two, study was type of surgery. In Swedish cancer trial, the surgery was the conventional kind of surgery, while in Dutch trial, total mesorectal excision was mandatory. So that was the only difference between the two trials. Look at the outcome. Both the trials have shown reduction in local recurrences. If you look at the Swedish trial, the local recurrences was reduced from 27% to 11%, which was statistically significant. Similarly, if you look at the Dutch trial, the local recurrences were reduced from 10.9% to 5.6%, which was again statistically significant. Now, another important observation you will make here that in surgery alone arm, if you compare both the trial, in surgery alone arm, there was higher local recurrences in Swedish rectal cancer trial up to 27% as compared to Dutch trial, which is in the local tumor control in the two trial. Again, answer lies in the type of surgery, because in Swedish trial, if you remember, it was a conventional surgery, while in Dutch trial, the total mesorectal excision was mandatory. And we had already seen that when you move from conventional surgery to total mesorectal excision, there is a drastic fall in local recurrences. So that was the reason that both the trial have different, local recurrences in surgery alone arm. If you look at the survival, Now, Swedish rectal cancer trial have shown improvement in overall survival, which was statistically significant. But in Dutch trial, the overall improvement was not there, and it was not, there was no statistically significant difference in overall survival. Now, again, the explanation that why we had, improved overall survival in Swedish rectal cancer trial and not in Dutch trial. In fact, uh, after this also, most of the new adjuvant chemotherapy, radiotherapy trials have not shown improvement in overall survival. It is only the Swedish trial which have shown improvement in overall survival. So explanation is probably because there is more reduction in absolute number of local recurrences in Swedish rectal cancer trial, because if you remember, the absolute reduction in local recurrences was around 16%, while in Dutch trial, it was only 5%. So more reduction in absolute number of local recurrences ultimately translate into an improvement in overall survival. So we can say that, the inadequate kind of surgery, because it was not TME, so inadequacy in surgery was compensated somehow by radiation in improving the local control, which was ultimately translate into an improvement in overall survival. So that may be one of the explanation of why we have improved overall survival. So if I conclude regarding the preoperative short course radiotherapy plus surgery versus surgery alone, I can say that it reduces local recurrences, no effect on overall survival if total mesorectal excision is performed. But of course, if total mesorectal excision is not performed, then definitely it may, improve the overall survival as well. And a third, no effect was seen on sphincter preservation. Now, in short course radiotherapy, basically the surgery was performed quite early, usually within 7 days. Then question was raised that improve the, am I audible?
Yes, yes, sir.
Yes, sir, you are audible.
Right. So it was thought that if we, delay surgery by 4 to 6 weeks, which is the standard time for most of other sites after preoperative radiotherapy, will it benefit further? So this was again, addressed by one of the trial where short course radiotherapy, 5 gray, 5 times, followed by total mesorectal excision done, and then divided into 2 arms. One, early surgery was done. In other arm, late surgery was done, and outcome was observed. They found that there is no difference in outcome, except downstaging was seen in higher number of cases in patient who had delayed surgery. And that is quite understandable, because as a radiation oncologist, we know that effect of radiation keep coming after 4 to 6 weeks after completion of radiotherapy. So naturally, if you are giving more time to the tumor to shrink, then naturally you get more downstaging in patient who will have surgery after 4 to 5 weeks. After this, as I said, the second step was that whether long course radiotherapy, means conventional fractionated radiotherapy, radiotherapy. And this was addressed by Stockholm 3 trials. It is a 3-arm trials, 1 arm short course radiotherapy followed by immediate surgery, means after 7 to 10 days. Second arm, short course radiotherapy followed by delayed surgery, means after 4 to 6 weeks. Third arm, a long course radiotherapy followed by surgery after 4 to 6 weeks. An interim analysis which was published in 2010 showed that anterior resection, or we can say sphincter preservation, was achieved in higher number of patients who underwent long course radiotherapy. Another advantage which was observed in this trial was that postoperative complication was seen less in patient who underwent long course radiotherapy. The matured data were published in 2017. So 3 arm, short course radiotherapy with early surgery, short course radiotherapy with delayed surgery, long course radiotherapy with delayed surgery. And the outcome, there was no difference in local recurrences. But certainly the post-operative complication was much less, and it was statistically significant in patients who had long course radiotherapy with delayed surgery. So we can say that interim analysis shows more sphincter preservation with lower surgical and post-operative morbidity in long course radiotherapy as compared to short course radiotherapy. So long course radiotherapy is better, we can say, than short course radiotherapy. In fact, a meta-analysis was published in 2000 for preoperative radiotherapy, which include short course as well as long course radiotherapy. And it showed that overall, survival was slightly better, and in neoadjuvant radiotherapy arm. Similarly, the disease-free survival was also slightly better and favoring the preoperative radiotherapy, but there was a major effect in local control, where radiotherapy arm had a better tumor control as compared to surgery alone arm. So if you look at this meta-analysis or preoperative radiotherapy, regime, it says that preoperative radiotherapy improves local regional control compared to surgery alone arm, level 1 evidence. With the exception of Swedish rectal cancer trial, none of the trials have demonstrated improved survival with preoperative radiotherapy, and explanation I have already discussed. Meta-analysis, of course, has revealed that there may be a small improvement in overall survival and cancer-specific survival with the addition of pre-op radiotherapy to surgery. But main impact of preoperative radiotherapy is in improving the local control or in reducing the local recurrences. Now, next step was that will there be any added advantage of adding chemotherapy with radiotherapy versus radiotherapy alone? Again, you will find so many trials addressing this issue, but I have taken just 2 trials just to not to confuse you. So I'm just limiting myself to these 2 trials. These are important trials. One is Polish trial, other is French trial. In Polish trial, radiotherapy was compared with chemoradiotherapy, but here was the short course radiotherapy. So short course radiotherapy compared with long course chemoradiotherapy followed by surgery, while in French trial, long course radiotherapy was compared with long course chemoradiotherapy followed by surgery. Let us look at the outcome. Now, both the trials have shown reduction in local recurrences. But of course, in Polish trial, it was not statistically significant. But in French trial, there was a statistically significant reduction in local recurrences. So chemoradiotherapy in local recurrences as compared to radiotherapy alone. Looking at the overall survival and disease-free survival, the Polish trial did not show any improvement or any difference in the overall survival as well as the disease-free survival. Similar kind of, result were observed in French trial also, which means that there was no difference in overall or disease-free survival. But certainly both trials have shown that there is an improvement in reduction in local recurrences with the addition of chemotherapy along with radiation. Now, another important observation of these 2 trials was that pathological complete response was seen in higher number of patients who underwent chemoradiotherapy as compared to radiotherapy alone arm. And pathological complete response um, later found to have a bearing in overall survival, which I will discuss in a short while. At the same time, as expected, toxicity was more in chemoradiation arm. A Cochrane meta-analysis was also published in 2009, which shown that local recurrences was less in chemoradiotherapy arm as compared to radiotherapy alone, but at the same time, toxicity was higher in chemoradiotherapy arm as compared to radiotherapy alone. So if I just give you some take-home messages comparing the radiotherapy alone versus chemoradiotherapy followed by surgery, the addition of chemotherapy to perioperative radiotherapy improves loco-regional control further and rate of complete pathological response. There was no improvement in sphincter preservation rate with the addition of chemotherapy. The addition of chemotherapy increases the rate of grade 3 and 4 acute toxicity. Important finding was that pathological complete response is much higher with the addition of chemotherapy. And this is a very significant observation because pathological complete response has a bearing in overall survival. And so pathological complete response has been categorized histopathologically into 5 categories. This is called tumor regression grading system, which ranges from TRG0 when there is no regression and up to TRG4, which reflects a complete regression. So depending upon the tumor regression, we divide into 5 categories: TRG0, 1, 2, 3, and 4. TRG0, no regression; TRG4, complete regression. And it has been seen that patient had TRG4, which means complete regression, they have better disease-free survival as compared to patients who have no regression or very little regression with a TRG score of 0 or 1. Similarly, another trial which shows that when there is a TRG regression or the complete regression, the disease-free survival as well as overall survival improves. Otherwise, it falls down if there is partial or no regression. Another trial which suggests that the disease-free survival and overall survival is better when patient having TRG good as compared to TRG bad. So tumor regression grade is very important, or we can say that pathological complete regression after chemoradiotherapy is a prognostic factor as well as probably a predictive factor also. I will discuss in a short while. Now in German trial, which I will discuss very soon, in German trial it was seen that as TRG increases, which means that from no response to complete response, the 5-year disease-free survival also increases. Also, 5-year distant metastasis-free survival increases, but there is no difference in local control rate. So this is a very, very interesting finding in German trial. What does it say? It says that the pathological complete response has no bearing in local control because there is no difference in local control whether you have complete regression or you have no regression. But if you have complete regression, then certainly 5-year disease-free survival improves drastically. Similarly, distant metastasis-free survival also improves. So we can say that if you have pathological complete response, then it is a good indicator for probability of distant failure and thus good surrogate for overall survival. Don't have effect on local relapse as I just discussed, but certainly have effect on distant failure. So this also suggests that pathological complete response is an indicator for sensitivity of the disease to chemotherapy. And probably patient with pathological complete response after preoperative chemoradiotherapy may be the subgroup who will be benefited with adjuvant chemotherapy, not all the groups. Because most of the trials I discussed, they have used adjuvant chemotherapy also, but adjuvant chemotherapy have not shown any improvement in overall survival because we were using adjuvant chemotherapy across the board. But with these findings, we can generate a hypothesis that probably only patients who have pathological complete response after preoperative chemoradiotherapy may be benefited with adjuvant chemotherapy, not all the patients. Now, these were the three, step evolution of preoperative regime. Now, when these trials were being conducted in preoperative setting, similarly, the parallel group were conducting trials in postoperative setting, which includes radiotherapy alone, chemoradiotherapy, and all the postoperative trials had shown that there is improvement in local control similar to neoadjuvant trial. But similar to neoadjuvant trial, postoperative trials again did not show improvement in overall survival, but they have certainly shown that there is improvement in local control or there is reduction in local recurrences. So the question is then, what should we use, preoperative chemoradiotherapy or post-operative chemoradiotherapy? Now, this question was addressed by German rectal cancer study or German trial. Now, here it is a two-arm study. One arm was treated with preoperative chemoradiotherapy followed by total mesorectal excision. Other arm, surgery first, followed by post-operative chemoradiotherapy. And again, after that, adjuvant chemotherapy was given. So it was just to answer our question that what we should use, preoperatively or postoperatively. Look at the outcome. First is compliance. Now, if you look at the compliance, it was much, much higher in preoperative arm as compared to postoperative arm. If you just concentrate on postoperative arm, half of the patient did not complete the planned treatment, while in preoperative arm, close to 90% patient completed the planned treatment. Now, toxicity 3 and 4 side effect, grade 3 and 4 side effect was seen much less in preoperative arm and higher in postoperative arm. As far as survival and disease-free survival are concerned, there was no difference between preoperative and postoperative arm. But certainly, if you look at the local control, the local recurrences reduced from 13% to 6% in preoperative arm. Or we can say that better local tumor control was observed in preoperative arm as compared to postoperative arm, and it was statistically significant. Another important observation of German cancer study, rectal cancer study, was that more sphincter preservation surgeries were performed in preoperative arm, and it was directly related to quality of life. Now, if you look at this table, now in preoperative arm, preoperative evaluation suggested that around 116 patients will require abdominoperineal resection. But after neoadjuvant chemoradiotherapy, when they opened, they found that 40% of the patient, around, or 39% of the patient to be more precise, they could do the sphincter preservation surgery. While in postoperative arm, initial evaluation suggested that 78 patients will require abdominoperineal resection. But when they opened, they found that 19% they could do organ preservation or sphincter preservation surgery. So we can say that in preoperative arm, higher number of patients were subjected to organ preservation. So we can say more sphincter preservation surgeries were performed in preoperative arm as compared to post-operative arm. So Just if I conclude about the German trial, we can say that preoperative chemoradiotherapy provides better locoregional control than postoperative chemoradiotherapy. More sphincter preservation surgeries can be performed in preoperative chemoradiotherapy arm. Less toxicity and better tolerability of preoperative chemoradiotherapy as compared to postoperative chemoradiotherapy. And this is very, very important factor, because as you have seen that 50% of the patient could not complete in German rectal cancer trial the planned treatment. So we can say there is much better compliance with with preoperative chemoradiotherapy, and yes, less toxicity in preoperative chemoradiotherapy. And after this, preoperative chemoradiotherapy becomes the standard of care in carcinoma rectum. The next question was that because 5FU we have to give 5 days continuous infusion, so it is cumbersome for patient. So can we reduce? Can we replace 5FU with with capecitabine? And this trial basically addressed this question. It is the similar trial as German rectal cancer trial. Only difference is that this time they used capecitabine in both the arm instead of 5FU. And they did not find in any difference in disease-free survival, overall survival, or local recurrence, but certainly they found that more organ preservation surgeries or more sphincter preservation surgeries were performed in preoperative arm. So if you can see that lower anterior resection was performed in 68% in preoperative arm as compared to postoperative arm, which is 42%, and it was statistically significant. So if now I summarize all the randomized trial, which I discussed so far, so let me put some question and then I will answer. First question is that are rectal tumor downstage with neoadjuvant chemoradiotherapy? Answer is yes. So most of the trials have shown that they are downstage with higher pathological complete response. Second question, does neoadjuvant chemoradiotherapy increases rate of sphincter sparing surgery? Most of the trials have shown no, but yes, German trials have shown higher organ preservation or higher sphincter preservation surgeries in preoperative arm. Third question, does neoadjuvant chemoradiotherapy improves the overall survival or progression-free survival? Answer is no. Most of the trials have not shown statistically significant difference in overall survival, though most of them have shown better overall survival, but it was not reached to statistical significance. Fourth, does neoadjuvant chemoradiotherapy reduces risk of local recurrences, distal recurrences? Local recurrences, yes. Most of the trials have shown yes. Distant recurrences, no. Next question, is there an increase in grade 3-4 toxicity with neoadjuvant chemoradiotherapy? Answer is yes. Most of the trials have shown that there is increased grade 3-4 toxicity. Next question, how is patient compliance with neoadjuvant chemoradiotherapy? Now, most of trials have shown that neoadjuvant chemoradiotherapy compliance was much, much better as compared to post-operative chemoradiotherapy arm. Now, finally, indication for neoadjuvant chemoradiotherapy, T3, T4 tumor, node positive disease, distal rectal tumor close to sphincter where APR is not an APR is the only option. And if you are able to reduce the bulk of the tumor with neoadjuvant chemoradiotherapy, probably you may get margin so that low anterior resection can be done, or you can provide a colostomy-free life. So that is another indication. Distal rectal tumor close to sphincter. But remember that if sphincters are involved, then we don't try to do a sphincter preservation surgery. Rather, we usually do upfront, abdominoperineal resection. Third, when it is, difficult to get a tumor-free circumferential resection margin. So when there is a doubt whether surgeon will be able to achieve a tumor-free margin circumferentially, that is another indication where you would like to do neoadjuvant chemoradiotherapy. Now let us look at some other issues like, can we replace 5-FU with capecitabine? I have already shown one trial, another trial, NSABP trial, which have suggested that there is similar efficacy with better tolerability of capecitabine. What's about the two drug? Like if we add oxaliplatin along with 5-FU, will it be having better outcome? Various trials have addressed this issue and they did not find any advantage of adding oxaliplatin. Rather, it increases the toxicity. Radiotherapy dose 45 gray versus 50 gray, various trials have shown that 50 gray is better as compared to 45 gray, especially to achieve more pathological complete response. Now, another issue is timing of surgery after radiotherapy. Now, this is a database analysis of around 7,000 patients which were taken from National Cancer Database, USA, and they analyzed the survival based on the time interval between radiotherapy and surgery. So they divided patient into various groups like patient who underwent surgery less than 30 days, 30 to 44 days, 45 to 59 days, 60 to 74 days, more than 74 days. And what they observed that when surgery is performed within 16 days, then there was no difference in overall survival. But if it is delayed for more than 16 days, then certainly it compromises the overall survival. So from this, we can say that surgery should be done before 60 days of completion of RT. Ideal is still 4 to 6 weeks after completion of radiotherapy. Another important question, which has cropped up very recently, and that is, can we avoid surgery altogether in patients who achieved complete clinical response after neoadjuvant chemoradiotherapy? So lot of studies are going on to address this issue, though still we do not know exact answer. We don't have level 1 evidence, but certainly there are studies which have suggested or which have given very encouraging result. One of such study is presented in 2015 in ASCO GI conference, where prospectively collected data from patient completing neoadjuvant therapy for stage 1 to 3 were analyzed, total 442 patients. Now, out of 442, 73 patients had complete clinical response. Now, these patients were matched with 72 patients who underwent surgery after neoadjuvant chemoradiotherapy, but who had pathological complete response. So these two cohorts were analyzed. Median follow-up of around 3.5 to 4 years. And what they observed that local differences in patients with complete clinical response was seen in 26% of the cases, but salvage surgery was very successful. And after salvage surgery, the pelvic recurrences was around 1.5%. So first message from this data is that it does not compromise the local outcome. Even if there is a recurrence, it can be salvaged beautifully by salvage surgery. When this cohort of patients were matched and with the patients who underwent surgery and who had complete pathological response, what they observed that between the two groups, there was no difference in disease-free survival or disease-specific survival or overall survivals. There was no difference, right? So we can say that patient with complete clinical response, 74% was NED at 4 years. They need to be followed up regularly, of course, because we need to detect local recurrences early so that we can, offer a salvage surgery. It can be easily salvaged by surgery successfully, as we have seen that after salvage surgery, there was just 1.5% local recurrences. Rectal preservation is observed, yes, is seen in almost 77% of the cases, and they have similar overall survival as with surgery. So with this, I finish my presentation by giving some take-home messages. Like number one, total mesorectal excision should be the standard surgical approach. Surgery should be performed by a trained rectal surgeon and not by general surgeon. Short course preoperative radiotherapy is an effective means to reduce the local recurrences, especially in early T3 lesion, but associated with higher morbidity. Preoperative chemoradiotherapy is better than postoperative chemoradiotherapy and should be the standard of care. Some very selective patients with complete clinical response may be treated with non-operative approach with higher rectal preservation rate. So with this, thank you very much. And if there is any question, you are most welcome. So Navneet, if there is any question.
Sir, there is a question in the chat box, sir.
Yes, you can ask.
Sir, I can read out the question for you.
Yes, please.
Should adjuvant chemotherapy be given in patients with complete clinical response?
So, okay. So that is why I try to address, the logic, why we should, find out the patient who will be benefited. I mean, these data, which I just showed to all of you, give some indication, or they generate a hypothesis that probably patient who have complete pathological response, they basically shows in vivo, sensitivity to chemotherapy. So if we give chemotherapy to these patients, probably we may get, overall survival advantage. Yes, of course, right now, if you look at the evidences, we don't have any evidences or level evidences which suggest that adjuvant chemotherapy in rectal cancer especially improves the overall survival. But still all of us usually, practice adjuvant chemotherapy. But certainly it is, we need to explore it in a randomized fashion, randomized trial, whether really this subgroup of patient who had complete pathological response, will be benefited with chemotherapy. Any other question, Navneet?
Sir, the next question, sir, I am Dr. Debanjan. Dr. Navneet is perhaps a bit busy.
Okay, Debanjan, yeah, no problem.
The next question is from Dr. Richa. What should be the timing for imaging after long course radiotherapy?
Time of imaging for what? Can you specify further for plan? Usually see, if you are asking before surgery.
No,
Yes,
sir, post-op RT response assessment.
You are asking post-operative radiotherapy.
Response assessment for surgery.
Okay, response assessment for surgery. Usually, the principle is same as, with other sites, most of the sites. Usually after, you say, 4 to 6 weeks.
So there is another question from Dr. Tania. What is the oncological basis for short course radiation in Ca rectum?
Okay. So oncological basis basically probably is that, with high dose of radiation, we can kill of course, the microscopic disease around the gross tumor, as well as probably the, hypoxic cells, which can be killed by, high dose of radiation. When you deliver high dose per fraction of radiation, the hypoxic cells are killed better than, when you use 2 gray or maybe, conventional fractionation radiation. So that may be the, probably the rationale.
Okay, sir. The question from Dr. Garima is total mesorectal excision a sphincter preservation surgery?
Total, see, sphincter preservation surgery has nothing to do with total mesorectal excision. You know, all kind of surgery, total mesorectal excision, basically ensure the complete removal of microscopic disease extramurally as well as circumferentially. The sphincter preservation depends upon the location of the tumor. If it is very near or close to the sphincter, naturally you are not going to get a 2 centimeter or more than 2 centimeter tumor-free margin without sacrificing the sphincter. So it has nothing to do with the sphincter preservation. The sphincter preservation is more function of location of tumor, where the tumor is located.
Sir, Dr. Devapriya Mandal has asked, what about neoadjuvant chemotherapy in the wait period after short course radiotherapy, and any evidence regarding that?
Can you repeat again? I didn't listen.
What about neoadjuvant chemotherapy in the wait period after short course radiotherapy, and any evidence regarding that?
Yeah, actually now, you know, as I said, there are a lot of combination, permutation of radiotherapy and chemotherapy, which have been tried in carcinoma rectum. You know, all sort of combination and permutation have been tried. So now people are trying that, you know, we give short course radiotherapy, then, you know, since we are waiting for surgery or we are delaying surgery, so in the meantime, we give chemotherapy also. So that is another, you know, approach which is being tried in carcinoma rectum. But
Sir, would you like to take?
still the standard of care, I will say, still the standard of care is only two. One is either short course radiotherapy followed by surgery, or chemoradiotherapy followed by surgery.
Sir, would you like to take more questions? There are roughly 10 to 15 questions more on the chat box.
No problem.
Okay, sure. Next question is how to manage patient with high rectal tumor, means to say bulk of tumor in rectum with sigmoid involvement versus bulk of tumor in sigmoid with rectal involvement.
So basically,
Okay.
basically, primarily sigmoid cancer going to rectum, or
Yes, sir. Yes, sir.
so primary treatment, yes, you know, because you can, once it, you know, if it is primarily in the sigmoid colon and then going into the rectum, so usually it should be treated like a colon cancer. You know, you have to do a wide surgery. You can easily get wide local, you know, margins all around the tumor. So it has to be treated like a colon cancer. You have to remove it and then followed by adjuvant chemotherapy depending upon your histopathological feature. But if it is primary, rectal cancer going into the sigmoid colon, that it has to be treated like a primary rectal cancer.
So Dr. Minal Iyer has asked that as margins are there for surgery up to 4 centimeters, so is there any margin for radiotherapy up to 4 centimeters as well?
So basically, we already, you know, take, you know, if you look at the field of the radiation, we take usually, you know, from gross tumor, we take around 3 to 4 centimeter margin, you know, distally, right? So which of course include the CTV as well as PTV. So that is the standard. Am I clear? So,
Yes, yes, sir. Dr. Gaurav Sharma has asked, will short course radiotherapy achieve PCR? CTRT, same as long course CTRT. I think that is what.
Can you repeat question?
Will short course radiotherapy achieve PCR the same as long course CTRT? I think that's what his question means.
Pathological complete response, he is asking.
Yes, sir.
Yeah,
Sir, is sir. Hello, sir.
Yes, please.
Hello, sir. Sir, Gaurav here, sir. Is the in rectum short course RT can achieve pathological complete response as long course CTRT?
Never, never. Because short course, you see, when you give short course radiotherapy, usually surgery is done within 7 days, right?
Yes, sir.
So tumor doesn't get enough time to shrink. We do not know. And even if you have seen one of the trial, if you give simply, radiotherapy, if you give simply radiotherapy, and then wait for 4 to 6 weeks for surgery, then
Yes,
there may be some complete pathological response. But when you add chemotherapy along with radiotherapy, the number of pathological complete response goes up.
yes, sir.
So short course may only achieve in cases where you delayed your surgery, say up to 4 to 6 weeks. So some patient, of course, the number will be very less, might achieve, the complete pathological response or complete clinical response.
Okay, sir. Thank you, sir.
Is that all?
Sir, there are actually 19 or 20 more questions appearing up.
Okay, I think you can send me then.
Yeah, sure, sir.
Yeah. Anyway, thank you very much. Thank you. Bye-bye.
Yeah. Thank you very much for the awesome class, sir. Especially the last conclusion slides will really help us all.
Thank you. Bye-bye.